All right. Welcome, everyone. On behalf of our divisions of Tribal Affairs in collaboration with the CMS Office of Medicare and CMS Office of Minority Health, I'd like to welcome you to everyone to the All Tribes listening session. My name is Michaela Holm. I work with Kaufman & Associates, and I'll be your moderator today. Today's webinar is titled How CMS Can Contribute to Reducing the Burden of Illness and Diabetes. I'd like to welcome everyone to today's webinar. The webinar series is awarded by Centers of Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policy of the Department of Health and Human Services or Centers for Medicare and Medicaid Services. And at this time, I'll turn over to Beverly Lofton.
Thank you so much, Michaela. Thanks for that introduction. My name is Beverly Lofton. I am a senior policy advisor at CMS in the Division of Tribal Affairs. This webinar is in collaboration with the Division of Tribal Affairs at CMS and the CMS Office of Minority Health. During this webinar, our presenter will present an overview of Medicare diabetes prevention and treatment services and obtain input on ways in which accessibility and use of effective Medicare diabetes prevention and treatment programs and services can be improved among American Indians and Alaska Natives at risk for or with type 2 diabetes. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native Outreach and Education website at go.cms.gov/AIAN. The website link will be added to the chat. We are pleased to be joined today on this webinar by Dr. Bill Mayer. At this point, I will hand the presentation over to Dr. Mayer to begin the presentation. So, Dr. Mayer.
Yes, thank you, Beverly, and good day, everyone. And thank you so much for joining us today. Again, as has been mentioned, my name is Bill Mayer, and I am a CMS fellow and expert consultant with the Office of Minority Health in the role of facilitating the work of CMS in developing an agency-wide strategy to reduce the burden of illness from diabetes. And we are particularly interested in what we can do to reduce the burden of illness from diabetes among populations within those that we serve who are underserved. And we are especially interested in your input. So thank you so much for being with us today. We will be taking notes, as well as the recording that we will have from today's session, and we welcome your continued input on what you hear today. And at the end of the presentation, you'll receive or see my email address, and I hope you will not hesitate to send me your thoughts. I will mention that about a week ago, we did send this presentation out to the Tribal Leaders Diabetes Committee, which is why you see that on the slide in front of you, because we know that the Tribal Leaders Diabetes Committee is a group of folks with particular expertise in diabetes as it impacts the American Indian Alaska Native people. And we thought it would be helpful to give folks a heads up and invite input in advance of today's session. And I hope that since we invited the Tribal Leaders Diabetes Committee members to join us today, that a number of you have joined us on this webinar. I do want to just mention that we're going to talk today about a little bit about the impact, as Beverly had mentioned, of diabetes on people we serve at CMS. We have some limited data on specific data related to American Indian and Alaska Native people, and we'll share that with you. We're also going to talk about some specific opportunity areas that we see as having potential for significant impact. And we are constrained, I just want to mention this, legally from giving any kind of specifics about future rulemaking. That's just the the legal and regulatory constraint that we work under at CMS, because we don't want to give any undue opportunity to certain segments of industry, for example, and others who may have certain agendas related to our policies. So I did want to mention that. So I'll have to be a little bit circumspect about the specifics about the future rulemaking. But I hope that by discussing where we see the big opportunities today, that we can have a basis for hearing from you about your thoughts about what can be done to address specifically AI and AN people who are enrolled in CMS programs. In terms of the impact of diabetes, I'm sure I don't have to speak to you all about what a tremendous negative impact diabetes has on people we serve. This is data for all people, all adults in the U.S. And I'll just mention that, at least among all U.S. adults, 3 out of every 4 American adults aged 65 and older have either prediabetes or diabetes. So it is a tremendously prevalent problem, as I'm sure you know, and even more prevalent among the American Indian and Alaska Native people. And not only does it impact complications such as blindness and end-stage kidney disease and amputations, heart disease, and other complications, but it also threatens the sustainability of our programs, because people with diabetes spend more than 2 times as much in healthcare resource use than folks who do not have diabetes. So there are multiple reasons why this is important. And not only is it a big problem today, but the prevalence of diabetes is expected to double by the year 2050 among adults. So it's a big and growing problem. We know that we have a significant opportunity when it comes to impacting and reducing the impact of diabetes among the people we serve, because there are services that have been shown to be dramatically impactful in reducing the risk of diabetes and complications of diabetes. And yet those services are grossly underutilized. So we know, for example, that obesity is a major contributor to the risk of diabetes. And we know that intensive counseling for obesity can be effective in having a modest effect on obesity. And yet it's used by less than 1% of people who are eligible for that. Diabetes screening is done with among less than 4% of people who are eligible for it. And use of the Medicare Diabetes Prevention Program is also less than 1%. In thinking about treatment opportunities, we know that diabetes self-management training is only used at 5% of people who are by 5% of people who are eligible when they initially receive the diagnosis of diabetes. And we know that people who have diabetes as a diagnosis are the majority of those folks do not meet at least 4 of the basic treatment goals in managing diabetes, whether it's hemoglobin A1C, a measure of glucose levels in the bloodstream, blood pressure control, cholesterol control, and smoking. We know the majority of folks do not meet just those basic goals. So we have lots of opportunity, even among services that we already cover within Medicare, for example. And we know that we have issues with underuse of these services among American Indian and Alaska Native people. And you can see here a data from our beneficiary survey within Medicare from 2022 on the receipt of certain comprehensive diabetes care interventions for people who are by different ethnicities and races. And you can see that in eye exams, in blood pressure control, in the use of cholesterol reducing medications, statin use, and adherence to statins. We see that that among American Indian and Alaska Native people, the level of use of these services is below that of other populations. So what I'd like to do now, as I mentioned earlier, is to go through what we currently cover today within Medicare. And I want to pause here to say that the bulk of our discussion here today is going to be focused on Medicare. But as I said earlier, our leadership within CMS, our administrator, has charged us with addressing all of the people we serve. And of course, that includes Medicare, but it also includes other programs such as Medicaid and the health insurance marketplace. And so our intention is to start with Medicare because that's where diabetes prevalence is the highest. And that's where we have the most policy levers, if you will, to impact diabetes. And so we thought we would start there, but we fully intend to continue our work to move from there to addressing Medicaid, people in Medicaid, and people who are in the marketplace. So what I'd like to do now, focusing on Medicare, is to talk about those interventions that I mentioned earlier, which can be effective and highly impactful when it comes to reducing the impact of diabetes. So let me start with diabetes prevention and the Medicare Diabetes Prevention Program as an example. And as I understand it, you all have had some familiarity with this program. I think we learned that there was a desire for more input into our program design than perhaps you had the opportunity to provide earlier. We're really eager to have your input as part of this broader view and welcome your comments about how we can make this more helpful, impactful for people in the American Indian and Alaska Native communities. So first, you may be aware that it's a one-year behavior change program for people with prediabetes, and you can see some specifics about how that program is structured. It has been demonstrated to produce weight loss, and very importantly, it's been found to prevent or delay diabetes among 70% of people who participated in the program, who are ages 60 and older with overweight and obesity. So a tremendously impactful program for those who are in the program. And as I mentioned earlier, we know we have a large number of people with prediabetes, but yes, nevertheless, we have only in the most recent data, less than about 5,000 people who have received these program services. So we have a significant opportunity here that is underutilized. We have a number of conditions of coverage under the Medicare program for the Medicare Diabetes Prevention Program. There are limitations to what needs to be present in terms of laboratory test results. For example, you can never have participated in the Medicare diabetes program before and can't have a history of diabetes or of end-stage renal disease. But the program is covered at 100% for those who are in the program. So we have this program highly effective, some limitations of coverage today, and really very low uptake among people who can benefit from it. Now I'd like to turn to a treatment example of an effective program. If you look at comprehensive diabetes care, we're talking here primarily about primary care visits, where physicians or other health professional practitioners can work to assess and manage blood glucose, blood pressure, issues related to ulcers and circulation in the feet and the ankles and footwear that can lead to infections. We management, screening and management of heart disease and chronic kidney disease, and referrals for eye examination. And you can see that each of these different primary care interventions can lead to dramatic improvements in complications among people with diabetes. Reductions anywhere from 1/3 to 90% in complications in terms of reducing the decline in kidney function, anywhere from 33 to 37%, and preventing diabetic blindness by up to 90%. And yet, as I mentioned earlier, the majority of Americans with diabetes who meet these goals, they do not meet these goals for receiving these services. And we have a very big opportunity here in addressing these people who have diabetes, are at risk for these complications, and where many of them can be prevented. We have here as well some conditions of coverage. We have an opportunity with what's called the initial physician physical examination with people who are new to Medicare. And then we have annual wellness visits that are covered for with primary care practitioners for people in Medicare. And these include coverage for assessment and counseling for these complications with no cost sharing from enrollees. And you can see that we also have some limitations on things that are not included in the initial physician physical exam or the annual wellness visit, and instead are covered under Part B with Medicare, but the enrollees have to pay a deductible and coinsurance. Referrals to subspecialists are also, like, for example, eye doctors or kidney doctors. Those are also subject to deductibles and coinsurance, which we know creates a barrier to enrollees receiving these services. And we also have issues related to medications with Part D coverage under Medicare. And there we've implemented and are implementing the Inflation Reduction Act, which was recently passed, which limits the cost sharing for insulin to no more than $35 per year, or per month rather. And then total out-of-pocket medication expenses are limited, as well as various programs that can limit price increases and negotiate prices for these meds to lower costs. Another area that we think is important is that to look at issues that are alternatively referred to as social determinants of health or health-related social needs. It's one thing to look at coverage and to look at cost sharing that enrollees have for these services, but there are other barriers to receiving these services, whether those barriers are related to housing or transportation or food security. And these things compete for resources for people who have social needs. And so we have some programs, as you may know, that are designed to address health-related social needs. These include things such as the special supplemental benefits for chronically ill. That's available through Medicare Advantage plans, but not in traditional Medicare. We have some innovation ideas or innovation programs and models that allow Medicare Advantage organizations or plans to offer broader benefits. We do have requirements to screen for health risk assessments and health-related social needs with special needs plans for people who are dually eligible, for example, for both Medicare and Medicaid. But these are not universally available programs. And then we also have limitations where we don't cover community health worker services, and we don't get the kind of data, the kind of quality data that we think is important to identify people who have health-related social needs, to assure that those people are receiving or even measure the receipt of health-related social needs benefits. And we don't have the data we need on race and ethnicity to be able to look at underserved populations and see and demonstrate that we are making progress there, which we know we need to make. Another element of our current approach to managing delivery of these services is to look at our approach of quality-based rewards and incentives. And as you may know, the Medicare program has rewards and incentives for enrollees to adopt certain health-related behaviors, or, for example, physicians to do a better job when it comes to the quality of care that they deliver, for health plans, and for large provider groups or accountable care organizations. And these programs are certainly motivating. We know they get the attention of physicians and health plans, for example. However, they are very broad-based programs. So, for example, when it comes to the merit-based incentive payment system for family medicine, for example, there are 65 measures that are taken into consideration when it comes to impacting the reimbursement of family medicine providers or practitioners. And 11 of those 65 are diabetes related. So broad program, limited diabetes focus to it. Similarly, when it comes to rewarding organizations, accountable care organizations, large numbers of providers in traditional Medicare, they can choose 6 or 13 measures, of which only 2 or 3 are diabetes related. There are star ratings, which are used to evaluate Medicare Advantage plans. These have 26 measures, only 4 of which are diabetes related. And then in Part D, similarly, 4 out of 10 measures that are diabetes related that impact reimbursement and enrollment. So we know we have a system in place that has the potential to impact the receipt of these effective services. However, there are some constraints around, at least currently, how these programs are administered and their focus or lack thereof with respect to diabetes. We also have an Office of Communications within Medicare that has relationships with partners and stakeholders, whether it's the enrollees in these plans, whether it's practitioners who are participating in these plans, suppliers and health plans and states. So a wide network of stakeholders in delivery of care for people who are in Medicare. There's networks that we have that the Medicare Learning Network has a number of publications that it publishes to help inform people about what's new and what is available within Medicare. Social media, emails, and website content. We also have a quality improvement organization and a quality improvement network that's designed to support providers and stakeholders in improving the quality of care that's delivered to Medicare enrollees, and regional offices that also exist to help support stakeholders in more locally and within regions who are interested in and have questions about or concerns about Medicare. So with this very broad and established method of communication, we have the ability to raise awareness and to promote the services that are so underutilized today. And this is something that we see as an opportunity as well. So that's just a brief overview of some of what we see as the opportunities we have to deal with and that we can apply to improving care and preventing diabetes, to reduce the impact of illness from diabetes. What we'd like to do is to ask for your input on 3 questions. And these questions are on the screen in front of you now. First is, what are the opportunities that you see for improving receipt of effective diabetes prevention and treatment among American Indian and Alaska Native Medicare enrollees? Second, what are the barriers to improving the receipt of these effective services? And third, what other considerations do you think are important for to be addressed? And what can CMS do, perhaps, to be supportive in that regard with diabetes equity, prevention, and treatment among American Indian and Alaska Native Medicare enrollees? And what I'd like to do is to leave this slide up and maybe just start with the first question. What are the opportunities that you see for improving the receipt of effective diabetes prevention and treatment services among American Indian and Alaska Native Medicare enrollees? And I'd welcome you to raise your hand or put a comment or question in the chat box. We have a question that of having a resource nurse that can be reached outside of the clinical environment. This is something that we think is important, and I think we have not within CMS we have not had a focus on community outreach to the extent that we think we could, and I think that it's an excellent point to be made that we have an opportunity here, particularly among people who understand the folks who are at risk or with diabetes in their home communities. We have another comment about promoting these programs when enrolling members, and thank you for that. I think that is a great time, a teachable moment, if you will, for people who are making that transition to Medicare, and something that I appreciate your mentioning. Another comment, more of a social aspect to individual tribes away from hub medical centers. And I want to make sure that I understand what's meant by more of a social aspect. I don't know if this refers to health-related social needs or more broadly, social and cultural norms, as well as the availability of services in individual tribes away from hub medical centers. But we do know that we have access issues. So at any rate, I think we do have an issue with access, remote access, particularly among folks who don't live in urban centers. And I think that that is an opportunity for us. We've seen and heard from people who deliver some of these services via telehealth, and who have used that during the pandemic, for example, that it has been helpful in reducing barriers to access. So I think that point is very well taken. So offering the opportunity for Medicare enrollees to receive these services at home. Thank you. I think that's an excellent point. One of the issues I'd like to mention while you're thinking about that, about telehealth, is the issue of availability of access to the technology required to have, for example, FaceTime or interaction in real time through the internet, and how much of that is a problem, and what your thoughts might be about how we might overcome some of those barriers. Another question I might ask of you all is what have you found to be especially helpful in your work in addressing the prevention and treatment of diabetes among American Indian, Alaska Native people? Always like to learn from best practices and to see if we can learn lessons from some of the efforts that might be going on through the Indian Health Service or more locally, that we could learn from as we improve upon our support for diabetes prevention and treatment.
We just had another one come in to the chat just now. And so the comment is, yes, norms and the cultural closeness associated to recognize individual tribe members versus broad managed care with multiple tribes best practice involved regulatory in the elderly events and being regular within respective tribes. The next one that is in the chat right now is transportation is a very big factor to receive services in highly rural locations. The second one is lack of MDPP suppliers in tribal communities is important. Another one that we have is offering the opportunity for Medicare enrollees to receive these services at home. Yes, access. More of social aspects to individual tribes away from hub medical centers. Promote these programs when enrolling members.
Yes.
And then the final one is having resource nurse that can be reached outside the clinical environment. And so if there's any additional comments, questions, or feedback that you would like to share, please put that in the chat or the Q&A box.
But these are all helpful feedback and information here you put in the chat. So thanks so much for adding that in the chat.
Why don't we move on to perhaps the next question, which is what are the barriers? I know we've heard some of that already, but what are the barriers for improving receipt of these services or other services needed for prevention and treatment of diabetes? What are your thoughts about barriers? Any others you would add?
So we do have one comment here. The payment structure for the MDPP is a considerable barrier for tribes. If the payment structure were streamlined, perhaps by utilizing the 0593T codes and or removing the weight loss requirements, then you may see an increase in MDPP suppliers. Many tribes in Oklahoma have NDPPs, but I do not know of any that offer the MDPPs due to the cost/benefit ratio.
If there's nothing further at this time, I would, first of all, I want to thank all of you for making the time to participate in today's webinar. We welcome your continued input as you've had time to reflect and think about these issues. And I hope you won't hesitate to send me an email with any additional thoughts you may have at william.mayer@cms.hhs.gov. And I would welcome just your feedback and reactions generally to what was discussed today, and your suggestions of how we might approach prevention and treatment of diabetes in a way that can offer the greatest benefit in reducing the burden of illness among people who are American Indian and Alaska Native, particularly in Medicare. And again, just as a reminder, we do have the plan to extend our work in Medicare to also include people enrolled in Medicaid and people who are enrolled in the marketplace. And we would look forward to hearing more and learning more about what you think has been successful in impacting diabetes among American Indian and Alaska Native people, so that we might learn from those best practices. So welcome any and all of that or other feedback that you may have. And thank you again for your time and your participation. And with that, I'll turn it back. Is it back to you, Beverly?
Yes. Thank you so much, Dr. Mayer, for that great presentation. And thanks everyone for the feedback that you provided. This should be very helpful. And as always, you can submit any comments or inquiries to the CMS Division of Tribal Affairs mailbox. And that mailbox can be found at tribalaffairs@cms.hhs.gov. And again, as Dr. Mayer mentioned, his contact information is right here on the screen, and that's william.mayer@cms.hhs.gov. So with that, thank you so much, everyone, for joining, and have a wonderful afternoon.